wait a minute or two and then get started. Okay, it's right about 12:30, so welcome everyone to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker today, I had some housekeeping items. If you remember, we used to be under the Hawaii Consortium for CME. The HCCME closed in December of 2022. So starting this month, all of our geriatric medicine CME will be under the Queens Medical Center CME. So I really wanted to thank the Queens folks for making the path very easy for us so we could offer our CME under Queens. So this CME activity is jointly provided by the Queens Medical Center and the UH-JABSOM Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find evaluations by following the link in the chat or at any time on our website or our email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. It's great pleasure for me to introduce our speaker for today, Dr. Chris Kurahashi. He was trained at Northwestern University for medical school, residency in neurology, and fellowship in neuromuscular medicine. He has been a practicing general neurologist at Kaiser in Hawaii since 2017, and he currently acts as the residency lead in neurology for their general medicine program. He has given many lectures over the years. He also participates in an interregional group within Kaiser for aducanumab, last year's amyloid-targeted therapy for Alzheimer's, and he will also be their representative in one for lecanemab, which, as you all heard, recently got FDA approval for Alzheimer's. So it's my great pleasure to welcome Dr. Chris Kurahashi.
Hi, so as Dr. Masaki said, my name is Chris Kurahashi. I'm one of the neurologists over at Kaiser. Are you guys able to see my slides?
Not yet, Chris.
Oh, okay. Let me see. Share screen. Okay, how about now?
Yes, we can see them now. Perfect.
All right, very good. So this will be a talk on dementia and sort of a neurologist approach. So the lecture goes, just to sort of jump right in, we'll review cognition briefly. In other words, how neurologists think. We'll discuss cognitive localization, which I think is really important as we start to discuss some of the advanced imaging techniques as well. I'll have a few cases of some less common dementias, and I won't discuss much on management. Just to note, I borrowed a lot of this from a lecture I give to the residents. So some of this may be things that you guys already know, but hopefully from a different angle. And when I say I won't discuss much on management, the reason why is that actually a lot of my most challenging cases, I wind up referring over to our geriatrics department. As you guys are aware, it becomes very challenging from the care and the social aspects. And that's where I think, I ask for a lot of help from you guys. You guys are actually better at the management than I am. Cognition, so we will review the big picture, sort of the major axes in cognition. We'll talk briefly about executive function, language and praxis, visual, spatial, and attention, and then a little bit about memory. I think of these as sort of the domains of cognition. And as I think about the different pieces of cognition, I always try to imagine, the brain. So first, the major axis is left versus right. Left mostly deals with language and praxis, whereas the right side of the brain mostly deals with visual, spatial, and attention. And then there's anterior and posterior, right? So the posterior part of the brain mostly deals with perception, whereas the anterior part of the brain mostly deals in action. And then there's the, oh, did I lose something? Sorry, this Zoom window came up for a second, but I'm still okay, right?
You're fine.
Okay.
Yeah.
And then there's the dorsal stream and the ventral stream. So this mostly deals with the visual processing, where the dorsal stream mostly deals with the where, and the ventral stream mostly deals with the what. So this is just to visualize, the primary sensory cortices, visual, auditory, somatosensory, where information first enters the brain. From there, it goes to modality-specific association cortex, and then to multimodal association cortex. And then from there, transmits to the frontal lobe to sort of begin driving our actions and our responses to that information. So there are different frontal lobe syndromes that deals with different sort of localizations within the frontal lobe. The dorsolateral prefrontal cortex deals with organization and planning. So patients with damage to this area of the brain will result in perseveration, ritualistic sort of behaviors, and on exam, they'll have impaired attention and impaired working memory. This is the part of the brain that's really undeveloped in toddlers, so I have to often remind myself as my toddler is running all over the place and completely uncontrollable that his, dorsolateral prefrontal cortex is just not developed yet. He's not able to focus his attention because he doesn't have that, the brain anatomy yet to do that. And then there's the mesiofrontal cortex, which deals mostly in motivation. Patients with damage here will have reduced socialization, reduced spontaneous speech and action, and in the most severe cases will be akinetic mute. And then there's the orbitofrontal cortex, which is responsible for mostly social behaviors. So patients with damage here will be impulsive, emotionally labile, and have inappropriate emotions and behaviors. And these frontal lobe localizations and specific syndromes will come back later when we talk about behavioral variant FTD, and the diagnostic criteria really sort of mirrors these specific problems and patterns. Another point that took me a while to understand, you may hear neurologists talk about frontal networks. What we mean is that the frontal lobe has extensive connectivity to deep gray structures, to the parietal lobe, to the cerebellum. And this connectivity is critical to the frontal lobe functions. And so damage to this structurally from white matter disease or stroke or cerebellar syndromes, or physiologically from medications, inadequate sleep, will result in frontal networks dysfunction, which presents with sort of milder forms of those frontal lobar syndromes, with milder forms of inattention or inappropriate behaviors. Language, so language resides in the dominant left hemisphere. I think about this as well in terms of the major axis, where it starts with perception and then goes to action. It starts with perception in the Heschel's gyrus, the primary auditory cortex, which then transmits to Wernicke's area, the parietal lobe, sort of that association cortex where we see language, understanding of language, which then transmits to the arcuate fasciculus, to the Broca's area where we see the, production of language. So when we test language, we always look at fluency, which we see with history taking or describing a picture. We will test comprehension with simple and increasingly complex commands. And we'll test repetition and reading and writing. And I bring up reading and writing specifically because there's an interesting syndrome which really highlights the importance of these connections, and that's alexia without agraphia. So there's this syndrome, it's mostly a stroke syndrome in neurology, in which patients will come in and they'll be able to write, but they'll be unable to read, which is sort of a very interesting phenomenon. And the reason why it can happen is that the association cortex in the left parietal lobe is separate from the two visual cortices, and a left PCA stroke, if it's large enough, may damage the left-sided visual cortex, as well as the corpus callosum, which is that connection between the right and left hemisphere. So the right visual cortex, which is intact, has no connection now to the language centers of the brain. And so patients come in, and because of this loss of connectivity, they'll be unable to read, but they will be able to write because that same areas of language understanding connects still to the Broca's area in the frontal lobes where language is produced. So they'll still be able to write. And in fact, they'll be able to write a sentence down. And then, 5 minutes later, when asked to read it, they'll be unable to read it. Just sort of a really interesting disease that really highlights the importance of the neural networks. And then we'll talk briefly about memory. So, memory can be divided in different ways. And just a note, I know the terminology here is a bit confusing, but when I think about short-term memory, I think primarily working memory, which resides in that dorsolateral prefrontal cortex, and so this is the ability to hold a certain number of numbers or a certain number of, pieces of information in our mind at a given time. with working memory, if it's sort of held there long enough, it can be encoded into long-term memory. In other words, sort of recent memory. This is memory that's maintained despite distraction. On exam, we test this, mostly using word recall, in some cases using image recall as well. And then there is remote memory. And so remote memory is sort of the memory of more distant events or skills, and remote memory is more distributed throughout the cortex. Important to note with short-term memory and long-term memory, with memory problems, right, we're always asking, is the problem an issue with encoding, right? Is the patient able to maintain information in short-term memory for long enough to actually encode it into long-term memory? Is it a problem with storage, or is it a problem with retrieval, right? And how good is their free recall versus recall with cues? And then the other way to divide up sort of more the long-term or remote memory is in terms of categories. So there's explicit memory. Explicit memory, I think of as I know that, I know about this thing, either an episode or a word or a concept, an understanding of ideas. And then implicit memory is we think of as I know how, right? So the procedural memory, right? The knowledge of how to do something. And emotional conditioning also falls under sort of implicit memory. Apraxia, I won't talk about at length. There's a lot of different types of apraxia, but it's basically an acquired deficit in a learned skill despite intact strength and sensation, right? So something that you used to know how to do, now you cannot, but your strength and sensation is intact. Is the definition of apraxia. And then, attention and neglect, just to note, neglect is defined as decreased awareness of some stimuli contralateral to a lesion, usually of the left side of space, because it's typically of a right-sided lesion. So by now we're probably all feeling like the mouse, right? Next we'll go over some cases. So case one, a 53-year-old woman came into me for evaluation of memory loss. She was having, significant difficulties, progressive memory loss over the past about 2 years. She was having difficulties with her teaching, difficulty navigating her lesson plans, and occasionally would repeat lessons on subsequent days and need to be actually corrected by her students. She was working as a chemistry teacher at the time. She was having a little bit of issues with shortened fuse and increased anxiety, and she reported no issues remembering events from her past or her childhood. Her MRI was normal. Her lab work was normal as well. This was her score. At Kaiser, we tend to use the SLUM score most often, but you could also be using the MOCA or the MMSE. But we did a SLUMS on her, and most notably her recall was severely affected, right? It was 0 out of 5. So this would be an amnestic pattern of, consistent with sort of an Alzheimer's type, but remember she's 53, so very young. So just again, to review the concept of memory, one of the ways we divide it up is in terms of temporal memory. In Alzheimer's, the first thing we lose, right, is memory of the recent events. And then as the disease progresses, we next will lose memory of more remote events. And then last to go is sort of the short-term or the working memory. And I think of it sort of like having a photo album, and you're taking out and throwing away the pictures starting from the most recent picture, starting from the end of the album and going backwards. And so you're slowly losing, memories dating back. So for her, because she was so young, we did sort of more extensive workup, pursued a PET scan. This is often how PET scans are reported out, at least when I get them. They'll comment on the qualitative appearance, what they can see with their eyes, what the radiologist sees, and then they'll comment on the quantitative appearance as well, in terms of what they see as they compare it, with the computer. And here they said brain metabolism looked pretty normal, but quantitative analysis showed some mild decreases in the left temporal and hippocampal regions, which may represent some early changes. Of course, with Alzheimer's, you would expect changes to be in the parietal and temporal lobes initially, and I'll show some pictures of PET scans in a minute. What is the FDG PET scan? It's a measure of glucose metabolism. So it's basically a measure of how the brain is using energy. And it's, in the realm of dementia, I think it's most useful to evaluate in cases where you're concerned for hypometabolism that will be either asymmetric, one side to the other, or where you think that there will be significant focality to the hypometabolism. This is sort of a picture of some PET scans. I think it's useful to think about PET scans in context in terms of the different diseases where they are, where they're sort of relevant. So you'll notice Alzheimer's and dementia with Lewy bodies, which of course are the two most common dementias that we deal with. We see hypometabolism involving most severely the bilateral parietal lobes, as well as in Alzheimer's, it involves the temporal lobes. In dementia with Lewy bodies, it involves more parietal occipital as well as the temporal lobes. I think what's difficult about this, there is a lot of overlap between Alzheimer's and DLB on PET scan images. And so I typically don't find it to be very useful differentiating, AD versus DLB on the basis of PET scans. However, other conditions such as frontotemporal dementia, you see a lot of frontal hypometabolism, which is very different from AD and DLB, and so potentially useful to identify cases of FTD. And then certainly for cortical basal degeneration as well, where we see a lot of right-left asymmetry, I think PET scans can be very useful for CBD. And then other sort of rare causes of cognitive impairment, of course, like malignancy or like inflammation or such as an encephalitis could be picked up on PET scan as well. And then just to mention the other type of PET scan that is currently I guess more rarely clinically used is the amyloid PET scan. Amyloid PET evaluates for amyloid deposition in the cerebrum compared to the cerebellum. They choose the cerebellum because amyloid doesn't tend to deposit there very much. It's a non-invasive method of diagnosing Alzheimer's pathology. To my knowledge right now, it's not available in Hawaii. You guys can correct me if I'm wrong. I mostly know what's available through Kaiser, and I think we don't have access to an amyloid PET scanner yet, but I'm not sure if you guys do it. And also I suspect that the availability of the amyloid PET scans is going to dramatically increase now that lecanemab's been improved, and pending sort of the decisions on coverage. You recall for aducanumab, you did have to prove Alzheimer's pathology before pursuing it, and so this is one of the sort of better non-invasive ways of proving amyloid pathology. It's what was used in many of the studies, and so I think the amyloid PET may increase in availability quite a lot now that lecanemab's approved. The other way to prove amyloid pathology is through CSF testing. So this is with a lumbar puncture. And what we look for is A beta and phospho-tau. Specifically, in early Alzheimer's, the amyloid beta is decreased because amyloid is sequestered into the amyloid plaques, whereas phospho-tau is increased, reflecting the neuronal damage. And so the amyloid tau index is lower. Look at these three things and compare them, and then can decide, if the pattern fits Alzheimer's, which this patient's, it turns out, did fit, was consistent with Alzheimer's disease. You don't have to remember, amyloid or tau and which one is up and down. If you order the CSF testing for amyloid or for Alzheimer's disease, it'll come back and just sort of tell you, if it is or is not consistent, like this chart here, the friendly chart does. And then blood testing, so this is sort of an interesting point. There is blood testing that is approved, where they can look at the A beta 4240 in the serum. It is expensive, and it's often, as of right now, at least not covered by insurance. But I do wonder if that may change as well. It would be good to have an easy, non-invasive way to diagnose Alzheimer's pathology. And, I haven't looked at this extensively, but I wonder if blood testing may be sort of considered good enough eventually. An important point here, biomarkers, they augment, but they do not replace the clinical evaluation. By example, a patient may have Alzheimer's pathology, say they're in their 60s or 70s. They may have some mild Alzheimer's pathology, but come in with a massive stroke and subsequently have cognitive impairment, and that would be more of a mixed dementia, but really more of a vascular type dementia rather than an Alzheimer's. Biomarkers will increase in age, with age, even in cognitively normal adults. Up to 10% of patients in their sixth decade may have some, positive Alzheimer's biomarkers. So we really have to use care when using the biomarkers to diagnose Alzheimer's dementia. But I do think one thing that's sort of an interesting and, in my mind, still sort of an open question, how many of those patients who have the positive biomarkers will go on to diagnose Alzheimer's? How do we choose the ones who more likely will? And, I wonder, and, I'd actually suspect to some degree, with the lecanemab study being positive, whether treating earlier, right? Treating patients in the preclinical stage of Alzheimer's dementia may be the key actually to really preventing, dramatically delaying the onset of the dementia. All right, so that was case one. Case two. So an 80-year-old gentleman with a history of high blood pressure and sleep apnea, he endorsed about 3 years of memory problems and specifically says he's frustrated because he has difficulty remembering the names of movie stars and people he should know. His wife reported some fluctuation in his cognition. At times he seems almost normal. At other times he will mix up stories, get confused in conversation, be unable to use his computer. He denies any of these issues. So this was his, so we did a slums on him as well. This was his slum score. And what you'll notice here is relative deficits. You see the red arrows, right? Relative deficits in calculation and relative deficits in visual spatial functioning, really completely incorrect clock draw, difficulties with calculations, with relatively preserved free recall, 5 out of 5 on free recall. And also, looking back through the prior scores that he's had over the years, a significant fluctuation, where we tested in 2018 and he scores a 20, 2019, it drops to 16, goes back up to 24, back down to 18, back up, so, and significant fluctuation sort of depending on the day that he's tested. So one thought about this, when you hear somebody coming in with a memory complaint, everyone, when they come in for cognitive problems, pretty much will say, I have problems with my memory. And so we always have to ask, is it really a memory problem? I'm forgetting recent conversations. Is this an issue with, memory storage? Is it encoding? Is it retrieval? Somebody comes in and says, I'm forgetting words. Is it a memory issue or is it an issue with aphasia? Our patient, right, I can't remember the names of movie stars or other people I should know. Is it a true memory problem or is it an issue with their visual spatial, right? Is it an issue with the what pathway? I get lost with driving, could also be a visual spatial where pathway problem. I'm having difficulties with cooking, could be executive dysfunction, it could be ideational apraxia. And so in this patient, of course, what I'm hinting at, I think it could very well be a problem with the ventral pathway for vision, forgetting the names of movie stars. So subsequently, he developed falls. He's taking longer to do his daily activities. He seems to be slowing down. On exam, he has bradykinesia, increased tone with cogwheeling, a shuffling gait. He endorses having visual hallucinations. At times, he's seeing his deceased relatives. He only tells you this when you ask him specifically, do you see people who shouldn't be there? He doesn't act on those. He knows they're not real. His wife is sitting there actually surprised, has never heard him say anything about this before. And he also endorses about 8 years in which he's been acting out his dreams, and actually him and his wife sleep in separate beds now because of it. So this, of course, is a case of Lewy body dementia. So this is the clinical criteria for Lewy body dementia. It's a dementia, it's progressive, cognitive decline, right? That's sort of the baseline to diagnose any sort of dementia. And the core clinical features of Lewy body, one is fluctuating cognition with pronounced variations in attention and alertness. And in fact, we've seen patients even who come in with such severe fluctuations where they become completely unresponsive at times, unresponsive, but their MRI is normal, their vitals are normal, their EEG is normal. And it turns out, a month or two later, they're diagnosed with Lewy body, and that's just, one of their fluctuations. The second core clinical feature are the visual hallucinations. In Lewy body disease, they tend to be well-formed and detailed hallucinations. And I'll talk a little bit more about that in a little bit. We see the REM behavior disorder, which may precede cognitive decline. And we see cardinal features of Parkinsonism. The features of Parkinsonism may, and often do occur somewhat after the cognitive features of DLB, so may not be present on initial evaluation. Some of the supportive features include a severe sensitivity to antipsychotic agents and hallucinations and other modalities and systematic delusions. One thing to note, there is a push to recognize prodromal DLB, in which some patients with Lewy body, actually the initial onset is a case of delirium. Delirium onset DLB there's a push to recognize this. And I think it's good to think about DLB in cases of delirium. And we've all had them, right, where patients come in, they're younger than you might expect for their degree of delirium. It's lasting longer than their sort of mild infection, which is already well treated. And you feel like it's just a little bit not adequately explained by by what's going on medically. And I think a lot of those patients, or some of those patients at least, will wind up going on to develop DLB. And there is also a psychiatric onset, where some of our older adults who come in with new psychiatric symptoms, and no prior history, may wind up having DLB as well. So Lewy body dementia, right? Lewy body is the abnormal collection of alpha-synuclein within neurons. This is prominent in DLB as well as in Parkinson's. Lewy body dementia represents about 20% of our dementia cases, and the 1-year rule is that if the motor symptoms are present for at least a year prior to cognitive symptoms, we call it Parkinson's. Otherwise, or in other words, if the motor symptoms onset at the same time or after the cognitive, we would call it Lewy body dementia. Alpha-synuclein also accumulates in MSA, but in that case, it's more so in the oligodendrocytes rather than the neurons. The advanced imaging we do for Lewy body dementia, it was actually fairly recently, I think, that DAT scans were approved for DLB within the past year. And what we look for is this sort of pattern. What we see here is basically 2 small dots, whereas in the normal case, you would see sort of comma shapes. And just to note, DAT scans, they aren't very high resolution. They're kind of blurry, hazy. But yeah, and all we look for is the dots versus the commas. And the dots, if you see those 2 dots, it indicates pathology, specifically some pathology relating to dopamine. I mentioned that prodromal onset DLB. I think just to draw attention to the similarities between delirium and Lewy body dementia, the fluctuating cognition occurs in both. The inattention, the altered level of consciousness, the visual hallucinations, the delusions are all shared features, between delirium and DLB. So important to think about. Right, and then to mention hallucinations, hallucinations come from basically one of a few phenomena. One is the top-down attentional, in which prior experience and expectations intrude into the scenes that we're perceiving. And the other is the bottom-up sort of perceptual hallucination. So in Lewy body dementia, it's primarily the former. It's an intrusion of a hallucinatory object, something from a prior experience, often a loved one that we've seen many times before, somebody who we expect could feasibly exist in the scene, sort of intrudes into the scene. And that's why those tend to be, there are our own cognitive constructs of the person. That's why they tend to be very well formed, doing often, realistic things that they really could have been doing in life. Whereas the bottom-up perceptual hallucinations can come from, sensory deafferentization, resulting in hyperexcitability, or cortical irritation, like in seizures, will result in hallucinations, but those tend to be much simpler, shapes, colors, rather than the more complex hallucinations we see in Lewy body dementia. Another thing that I think is interesting, Lewy body dementia is associated with a lot of actually, conversion disorder. So similar false perceptions may result in compensatory motor outputs or suppression, and result in apparent, conversion or psychogenic appearances. Lewy body is actually associated with conversion disorder, associated with psychogenic tremor, as well as the true Parkinsonian tremor that we see in DLB. And I think it has to do as well with some of these false perceptions resulting in abnormal motor outputs and responses. All right, so moving on. So case 3, A 61-year-old male is referred for cognitive problems, and he is brought in by his wife. About 2 years prior to the presentation, he began to fall for online scams involving women. This was not discovered until fairly recently. About 10 months prior, he began to have difficulty finding his way in areas he should know. He began to have difficulty doing tasks that he previously could do easily, such as mechanical work on his car. And around that time, he began to have a change in his mood and was no longer his usual joyful self and began to lose interest in activities he used to enjoy. 6 months ago, his voice changed. He began slurring his words, and he began to notice some weight loss as well as some leg weakness. So this exam, he was oriented to person and place, but not year. He could not spell backwards. He could not do any sort of complex commands. He couldn't repeat, and so I think, notably in this patient, I did not do a slums. I think it's important to note if you have somebody who has really severe inattention, it really precludes any further cognitive evaluation. Attention is really necessary for all the other domains of cognition to work well. You have to really be able to focus, right? To get reliable tests, to get reliable results. Also on exam, he had some dysarthria and tongue weakness. He had diffuse weakness with 3+ reflexes, foot drop. This was his MRI scan. And you can see by the MRI that there's sort of an asymmetric atrophy that's frontal predominant here. You can sort of see the frontal lobes are shrunken and kind of pulled away with a lot of extra space on the front. So just a reminder about the different frontal lobe syndromes we discussed at the start, right? The dorsolateral prefrontal cortex involved in organization and planning, the mesial frontal cortex involved in motivation, and the orbital frontal cortex involved in appropriate social behaviors. So when we look at this patient, he was falling for online scams involving women, right? And this is that orbital frontal cortex dysfunction where he's having impulsive behaviors, socially inappropriate behaviors, right? He's brought in by his wife. He's been happily married for many years. So these are sort of inappropriate behaviors that are really brand new for him. He is having difficulty doing tasks like mechanical work on his car. And this represents dorsolateral prefrontal cortex dysfunction, in which he's having difficulties with organization and planning. Mechanical work requires a lot of steps, a lot of planning ahead to make sure you have the right tools and that you're doing things in the right order. And he's now unable to, and that reflects difficulties with organization. And then a change in his mood in which he's no longer his joyful self, lost interest in his activities. He sort of stopped doing a lot of the things he used to enjoy. He's no longer really seeing his friends. His friend groups have sort of pulled away. And that reflects, the mesial frontal cortex dysfunction in which he's now more amotivational. He's got reduced socialization. And on exam too, he's not producing as much speech or action as maybe he would have 1 to 2 years ago. So this is a case of behavioral variant frontal temporal dementia. So again, the baseline is you have to have somebody who's having a progressive cognitive decline. And then you look for 3 of the following cognitive symptoms, early behavioral disinhibition with socially inappropriate behaviors or loss of manners or impulsive behaviors, which again correlates to the orbital frontal cortex, right? Early apathy or inertia, which correlates to the mesial frontal cortex, early loss of sympathy or empathy, and then those perseverative, stereotyped, or ritualistic behaviors, which correlates to the dorsolateral prefrontal cortex, the hyperorality, dietary changes, and the neuropsych profile is one where the deficits in executive tasks appear to be impaired to a greater degree than memory and visual spatial function. FTD, this represents about 5 to 10% of dementia cases. Usually onsets younger than our other forms of dementia in the age range of 45 to 65, rarely onsets after the age of 75. At times can be seen as early as the 30s. It is very challenging. Patients may not be aware or able to identify their changes. And because it presents younger and because it presents in people who are physically pretty fit and may still be working, may still be caring for young children, may still be caring for their elderly parents, it presents with a lot of legal difficulties and financial difficulties. And, I think in a lot of ways, some of my most challenging, my most haunting cases have been sort of this FTD, and at times I feel sort of in a way limited, almost powerless in my ability to help. We refer them to social work, to associations like the Association for FTD, to lawyers specialized in dementia. We try to plan ahead as best we can, but again, it's often unsatisfying. And it can be familial in 20 to 40% of cases. And just to list some of the genetics, this patient turned out to have a case of ALS FTD. The common genetics there are C9orf is the most common, and then we also test for FUS and TDP43. In FTD, as I mentioned previously, what we see is primarily frontal lobe hypometabolism on the PET scan. I think FTD is actually one of the best indications for the FTG PET scan, because it is really very different in the pattern from the other types of dementia. And again, focality correlates to the cognitive presentation. I didn't mention it extensively, but PPA, the primary peripheral aphasias, are also the other type of FTD, right? So we mentioned the BB FTD, PPA is the other sort of aphasic variants, and those also have very specific focal abnormalities on PET scan, making it useful in those cases as well. All right, so case 4, and this will be my last case, but it was an 81-year-old gentleman who came in with multiple medical problems, high blood pressure, CKD, Parkinson's. He came in with acute onset of confusion, so I'm called to the ER to evaluate because he's having confusion since 9 a.m. The symptoms came on while he was playing pickleball earlier that day. In the emergency room, he's confused. He's asking his wife questions repeatedly. He's not sure why he's in the hospital. He doesn't think anything is wrong. He feels a little bit confused, but otherwise feels pretty well, and he's not sure what's going on. So we're called to the emergency room. His exam, he's mostly looking to the right. He names objects only on the right side of the stroke card, so he does name them correctly, such as key and chair. When presented with 2 stimuli, he extinguishes on the left to vision and to light touch. So this, a few points about this, he does have the underlying dementia, but he presents acutely with neglect. And I just want to highlight, neglect can be easy to miss. It's something we sometimes have to look for specifically. The way we test for neurology, we give people what's called double simultaneous stimulation, right? So we hold up, our fingers on both sides, and we see, can they see it on one? Can they see it on the other? And then when we hold up both, do they ignore one side of space? And that's one of the ways we test for sort of more subtler features of neglect. And that's what he had. He was extinguishing on one side. He was doing that to vision, and he was doing that to light touch. And when you see that, and if they are able to see on that side, you know that it is primarily a problem with attention. When not looked for specifically, it's often attributed to more global problems with cognition, which can be a problem, right? Because if it's a focal problem related to a new onset stroke, you don't want to misattribute it in somebody who's older and has other cognitive problems. You don't want to misattribute it to a more global process, because you may go down the wrong, diagnostic, the wrong management pathway. There's also a big inequity of neglect. Neglect is only 2 points on the stroke scale, whereas aphasia is 7, and it's very unequal in that way. So it's something we really have to be aware of and thinking about when we examine someone. Also, people won't tell you, right? There's anosognosia. They're not aware of their deficit. So when you go to examine someone, they won't tell you that I'm not paying attention to half of space, because they don't know. To them, that area just does not exist. And notably, neglect above and beyond other features, it dramatically increases fall risk in the hospital. Patients aren't aware of their limitations. And so these are the patients who, despite their leg being really weak, will be unaware that their leg is weak. So they'll try to get up out of bed, right, and get themselves in trouble. And they're also inattentive to half of space. So they may not be aware that there's something in their way on the left side. They'll crash into the door frames on the left. They'll trip over objects on that side, and so something to be aware of and to be thoughtful of in our patients. So he has a small right parietal stroke, not large enough to cause other features, but enough to cause a little bit of neglect. So this is a case of vascular dementia. So vascular dementia is a first gene to dementia, right? Cognitive decline. Second, you need cerebrovascular disease defined by history of stroke or stroke evident on imaging, CT or MRI scans, and a temporal relationship between the two, right? You want to see the onset of dementia following the stroke or following the cognitive decline following the changes on MRI. And the best history is if you can get that stepwise cognitive decline, although often it's not like that. The types of vascular dementia, number one is the post-stroke cognitive impairment. This has a very variable presentation depending on the location of the infarct, the location of the damage. So it could present with, deficits in a variety of different places in the cognitively. Second, there is subcortical vascular ischemia. This is a sort of more classic type of vascular dementia where you do the MRI, you see the, extensive deep white matter disease. And then there's the multi-infarct type of dementia, which is often presents with that sort of stepwise decline, hemorrhagic. And then, very common is mixed. Mixed dementia is about, in the studies, at least they'll say it's greater than 40% of patients actually have a mixed dementia, meaning that they'll have vascular dementia, but if you do the pathology on their brains, if you do the autopsy, they'll have some other dementia pathology as well, most often Alzheimer's or perhaps Lewy bodies. One point about the deep white matter disease, you remember I mentioned the frontal networks. Specifically, so the frontal lobe, again, has this extensive connectivity. And you can imagine with all of this connectivity that's critical to the frontal lobe functions, if you have a lot of deep white matter disease, it disrupts a lot of those connections, which is why we talk about frontal networks dysfunction as one of the main presentations of that subcortical sort of white matter ischemic disease. And it presents with, more of a broad presentation, I would say, but specifically dysfunction in the frontal lobar areas, behavior change. They may become a little bit more amotivational, though not quite as severe as BBFTD. They may have a little bit of frontal lobe, dorsolateral prefrontal cortex, a little bit of disorganization, difficulties with attention, though again, not as severe and usually presenting at an older age than the true FTD. And then just to, put this slide up, what we do to try to prevent progression in vascular dementia, control risk factors. This is the American Stroke Guidelines, controlling hypertension, diabetes, cholesterol, smoking, increasing activity. And if you look at this and sort of think about, the general recommendations for dementia patients, if you were to add, some social activity, cognitive engagement, those are some more main recommendations for preventing dementia progression in general as well. And that is what I have. So thank you all for your attention. And these are some of my references as well.
Dr. Kurahashi, thank you so much for an excellent presentation. For our audience, please feel free to either unmute yourself and ask your question, or you can type the question in the chat box if you'd like. While we're waiting, Chris, I had a question for you about genetics. You mentioned a little bit about some of these conditions being somewhat genetic. And what do you do as far as genetic counseling or genetic testing for some of these conditions?
Right. So it depends. The two that I think about genetic testing the most often, I would say, is FTD. For FTD, pretty much everybody that comes in with FTD, I'll send for genetic testing. I send them to Dr. Ng. Kaiser, we have a genetic counselor, Dr. Ng. And so I just refer them to him. And what he'll do is, because I don't really, they're much more expert at getting into the genetic counseling. And there's specific things with genetics, right? It impacts, it can impact things like life insurance, long-term care insurance to be diagnosed with a genetic condition. It impacts how we think about family members as well. Not every family wants to know, and I think it's just best for them to really see somebody who's trained in genetic counseling before sending the testing. So I refer to him, and then he just sends them, and almost always he'll just send one of these next-gen panels. If you type in, FTD into, FTD and genetics into Google, and then, Quest or whoever will have a next-gen panel that he looks through them and sort of decides which one is the most comprehensive at the best cost, and then he'll send out the, the appropriate panels. The other one we think about it a lot is early onset Alzheimer's. So young onset Alzheimer's will send it as well. There it is, mostly presenilin 1, presenilin 2, and amyloid precursor protein that we send for the for the really young onset, and then we'll also send the ApoE testing to sort of risk stratify in our young onset as well. Of course, ApoE4 is the highest risk, right? And again, I do the same thing. If somebody comes in with Alzheimer's and say they're in their 50s or 60s, or say they have a strong family history, even if they're a little bit older, but maybe their family history is very strong, I still may send in that scenario too.
Okay, thank you. Are there any questions from our audience? If not, I'll ask another question about the two Alzheimer drugs, the two new ones that have been approved. The one most recently was lecanemab and aducanumab, I guess a year and a half ago. Could you give any comments on both of those?
Yeah, so first aducanumab, I think it's a little bit clearer. From my standpoint, Kaiser had this interregional work group where we talked about aducanumab. We looked through the data, understood the FDA approval. As you guys know, it was very sort of contentious, the approval. Yes. Their advisory committee actually recommended against it. They wound up approving and they actually didn't base their approval on clinical improvement, right? Because the clinical improvement on the two studies, the ENGAGE versus the EMERGE study, one showed improvement, the other showed no benefit. And so, they felt that evidence, even the FDA agreed that evidence was not good enough. And so they based it off of surrogate markers of amyloid clearance. The surrogate markers were very encouraging, right? We did see really good amyloid clearance, and yet, clearing amyloid is not what I care about as a clinician, right? What I care about is my patient going to improve with this treatment? And on the other side, there was about a 30+% risk of ARIA, right? The amyloid-related imaging abnormalities, which is either edema or hemorrhage in the brain, which is very significant, right? And so our interregional work group recommended against aducanumab, so I have not been using it at all. And I think a lot of sort of organizations went the same way. Although I know that, it has been FDA approved and available, I haven't used it at all. So I don't have any real clinical experience with it. And whenever it comes up, I've always recommended against it and sort of told my patients, if you want, an amyloid targeted therapy or something, an advanced treatment for Alzheimer's, consider participating in a trial. And then, as of a few days ago, lecanemab gets approved, and I didn't really, I put in a couple of slides on lecanemab as well. So I'll just go through this briefly, but, the study was actually pretty good, right? 1,800 patients, 50 to 90, amnestic MCI mild Alzheimer's, and Alzheimer's pathology by amyloid PET. They used, I think the biggest one, or the one that I best understand, the rating scale I understand best, they used was this clinical dementia rating score. And they showed almost a 0.5 improvements. I think one of the big questions that I was wondering about, is it clinically meaningful, right? So they show a benefit, but is it really a big clinically meaningful benefit? And this CDR scale, a difference of 0.5, it actually probably is clinically meaningful. I think it probably is. It's not a huge benefit, but I think it is sort of a change because, it represents, are they having memory problems just very mildly, or is it like pretty significant, pretty frequent, intermittent, more so 50% of the time, maybe they have memory problems. So I think it may actually be a real benefit worth chasing. So I think it is sort of a clinically meaningful benefit. And then, their safety, it was actually better. Their ARIA-H and ARIA-E was less for lecanemab compared to aducanumab, markedly better, and their serious adverse event was not that, 14% was not that severe. So, I'm glad it was approved. I'm glad that we have an amyloid targeted therapy. And I think it represents really a sea change in the way that we're going to think about managing Alzheimer's as this one gets approved. And then as we get more, right, I think this is really just the tip of the iceberg. There are a lot of unanswered questions. I think I have concerns about it, mostly revolving around, us, the clinical side, the practical side, right? These patients, you had to prove amyloid pathology, which I think makes sense, right? If you're going to embark on a tens of thousands of dollars a year treatment for the rest of someone's life, and they have, they're 65 and have, you really want to be sure that the disease you're treating. So I think that is a requisite, to treatment. But it's expensive, right? Like I said, I don't think we have an amyloid PET scanner available. Is there one in the community? that you guys are aware of?
Not that I'm aware of, but the Queens, I know there's some of the Queens outpatient people are on. Do you all know if it's available? Marina says no, none, yeah. Unfortunately.
That's kind of what I thought, but I'm sort of siloed here in Kaiser, so sometimes things happen I'm not aware of. But so that's one thing, right? And without the amyloid PET scanner, I think we may be left LPing a lot of people. And I mean, I don't know what that's going to look like if you try to get an LP on everybody who has Alzheimer's.
Yeah,
it's going to be overwhelming for the people doing the LPs, or for the interventional radiology, if we go that route, doing the LPs, it's going to be overwhelming, that patient volume. We'll be looking at very long wait times. Which is why hopefully the blood testing, if the insurance companies decide that the blood testing is good enough, that would be great. And they start to cover it, then that would be very much, much easier. And hopefully the way that this winds up going. So that's one issue I have. The cost concerns I'm worried about as well. I suspect, and I think this one was FDA approved for Alzheimer's in general, right?
I think so, yes.
Much like aducanumab. And so, it's not just the early Alzheimer's patients, it may be everyone, which is a very large population of patients to be treating, with a very expensive medication. I mean, it's going to be overwhelming in terms of the healthcare cost. And then, yeah, the risk of hemorrhage is a real concern. There was recently a report in Science, and I only know about this because I've been getting texts from my colleagues, but over at Northwestern, they had a case where somebody came in with a stroke and was given TPA and then had a massive hemorrhage and died. The rate of hemorrhage after stroke for TPA is not that high, but she was on the study for lecanemab. She was getting lecanemab. And so that question of, can we treat patients on lecanemab with TPA? I don't know. Can we anticoagulate them? I also don't know. If you told me that somebody has a 10% risk of intracranial hemorrhage, I would never put that patient on anticoagulation, right? Mm-hmm. You just wouldn't. And so it's going to be that's going to be difficult too. I don't know the answer to that. And I have a lot of patients who are older, who have atrial fibrillation and stroke, who need their anticoagulation and, who are developing Alzheimer's. What am I going to do with them? Not sure. Until further notice, I'm not sure, but I probably would not anticoagulate them.
Good point. I know that Medicare had not approved Aduhelm. I don't know what they're going to do with the new medication. So I guess time will tell whether or not they approve that or not, for whether they'll pay for it. Yeah.
I bet they approve it.
Yeah.
I have strong suspicions they will. I mean, you guys looked at the data. I think the data is actually pretty good. I think they'll have a hard, I think they're going to approve it. And we'll just have to sort of, hopefully we're all planning ahead, and I think we're going to have to deal with the follow-up. And the truth too is that if not this, there's going to be one that works, right? So these systems will have to be in place because, if not lecanemab, then there's, cazenumab and, all of these other ones that they're testing. I think one of them will wind up getting there.
Johnny has a question about history of intracranial hemorrhage, cerebral amyloid angiopathy, or being on anticoagulation. Are those contraindications to lecanemab? I think you covered that a little bit, but what if they have a history of a hemorrhage or cerebral and amyloid angiopathy? Would you consider that more or less a contraindication?
Yeah, I think CAA. I mean, I'd have to look back at the studies and see they probably address that too. I would consider it an absolute contraindication. I would not put somebody on lecanemab if they have cerebral amyloid. And you're right that that's going to be a big issue because a lot of those patients, overlap with our Alzheimer's patients. Intracranial hemorrhage, it may depend upon the cause. If they had it 40 years ago and was a secured aneurysm, or they had a subdural hemorrhage and you don't think that they're at risk of that happening again, maybe, right? Or if it was a hypertensive hemorrhage and now their hypertension is well controlled, those patients are probably at lower subsequent risk for hemorrhage. So, I mean, I would have to see like the product labeling too, and all of that. I haven't had these discussions with people who are more well-versed in this than I am, but, I think it might depend a little bit on how high you think the risk of hemorrhage is. But CAA would be a definite no. Parenchymal intracranial hemorrhage of an unknown cause would be a no. Intracranial hemorrhage related to malignancy, what have you, would be a no, yeah.
Thank you, Chris. Any other questions for Chris? It's been a very interesting discussion. Okay, we'll give everybody another few seconds. Please speak up if you have a question or put something in the chat box. If not, Dr. Kurahashi, thank you so much. That was an amazingly informative presentation. Really appreciate you doing this. Michaela has put the CME link into the chat box. Please don't forget, if you want CME, you do need to do an evaluation, okay? So everybody, please do your evaluation for your CME. Chris, thank you again. I will definitely invite you to at least speak to our fellows again, and maybe even come back for grand rounds. That was an excellent presentation.
Yeah, thank you. Thank you for inviting me.
Okay, take care. Bye-bye.